Hello, my name is Dallas Holliday. I am a fourth-year emergency medicine resident with Midwestern University. This video is a tutorial for performing bedside ultrasound to assess the abdominal aorta for aneurysm. The purpose of this lecture is for you, the viewer, to understand when to perform ultrasound for AAA, how to perform the ultrasound, why we perform bedside ultrasound, and some troubleshooting tips. First, let's talk about when to perform this exam. When do we use bedside ultrasound for AAA? Whenever we have patients presenting with complaints that are consistent with possible symptomatic AAA or rupture. Consider this exam in patients with syncope, unexplained hypotension, abdominal pain, altered mental status, cardiac arrest, and flank pain. Less than 50% of patients will present with the classic triad of hypotension, pain, and pulsatile abdominal mass. Remember, an abdominal aorta is considered aneurysmal if it is greater than 3 centimeters in size, and it is eligible for repair if greater than 5.5 centimeters or symptomatic. Next, let's talk about the why. So why do we perform ultrasound in these patients? It's quick, easy, and non-invasive. Additionally, a ruptured AAA is a surgical emergency. Even when rapidly identified, these patients have high morbidity and mortality. Survival is directly related to time to diagnosis, so we want to find these patients on initial exam, not when they're coding in the CT scanner later. The risk of rupture is directly related to size. Aneurysms less than 4 centimeters have a low rate, approximately 2% per year. However, those greater than 7 centimeters have a rupture rate of 20 to 50%. If you find a AAA, complete a FAST exam. Although negative FAST cannot rule out rupture, remember ruptures are more likely to be retroperitoneal, a positive FAST exam in the setting of AAA, especially when hypotension is present, is extremely concerning and warrants an immediate phone call to your surgeon. Next, let's talk some anatomy. I know anatomy might cause some painful medical school flashbacks, but this is only about 30 seconds, so please stick with me. Remember, the abdominal aorta is a retroperitoneal structure beginning at the hiatus of the diaphragm, coursing down until it splits into the iliac arteries around the umbilicus or T12. There are several main arteries that branch off the aorta. Identification of these arteries is not particularly useful in rapid assessment, so we're not going to spend a lot of time on them. But remember, 90% of aneurysms occur below the renal arteries, which is why scanning the entire aorta is crucial. Although not pictured here, remember the inferior vena cava runs down the right side of the aorta. Be careful not to mistake the IVC for the aorta on exam. We'll discuss some tips and tricks for differentiating the IVC from the aorta in a minute. And now finally, let's discuss how to perform the exam itself. So for this exam, you're going to start with the curvilinear or phased array probe in the patient's midline, just below the xiphoid, high in the epigastrum. You're going to hold the probe perpendicular to the patient, aiming straight down. The left lobe of the liver typically provides a nice acoustic window to find the aorta. Once the aorta is identified, slide the probe down towards the patient's umbilicus, carefully measuring the entire aorta visually. Record exact measurements with your calipers at 3 levels, proximal, middle, and distal. Although you only take these formal measurements at 3 levels, you want to scan the entire aorta carefully as small saccular aneurysms may be missed. When measuring, it's important to measure outer wall to outer wall, as a clotted thrombus dissection may produce a falsely narrow lumen. So again, we're going to start with the probe high in the epigastrum. As seen here, the liver often provides an acoustic window. Start by identifying the vertebral body by finding the horseshoe sign created by the hyperechoic body with posterior shadowing shown here, and the posterior shadowing behind. Your aorta is going to be directly anterior to this, as seen here, and then the IVC is going to be off to the patient's right. Remember, IVC is going to be a thinner walled vessel. It's going to be slightly compressible, as demonstrated here, and it's not going to be pulsatile, which is something you can see in real time. So next, after you've scanned the entire length of the aorta in the cross-section view, you're going to rotate the probe 90 degrees so the probe indicator is pointed towards the patient's head, and you're going to do the same thing in the longitudinal view. You have to take care, though, that you don't fan to the patient's right because you don't want to falsely measure the IVC. Remember, the IVC is going to be thinner walled, compressible, and may have some respiratory variation. If you're not sure, go ahead and just rotate the probe back to the cross-section, gather your bearings, and then go back. And this image demonstrates that we can see the celiac and superior mesenteric artery branching off, which does suggest that we're viewing the aorta. And then again, you're just going to scan the whole thing in the longitudinal view. So here's a great video from the guys at 5-Minute Sono tracking the aorta the entire way down. So you can see we've got our vertebral column, aorta directly anterior. You're going to follow that all the way down until it bifurcates into the iliac arteries. So here's a great example of a triple A. As you can see, we got this big, so here again, spine, and then we have this huge aorta with looks like some dissection, thrombus formation. So this is concerning. Here's a great example of an aortic dissection with thrombus formation. As you can see, if you measured inner lumen to inner lumen, you would get a falsely normal measurement of 2 centimeters. However, when you measure outer wall to outer wall, you capture the entire width of 7 centimeters, which is concerning for aneurysm. Unfortunately, patients presenting to the emergency department are not always ideal. Abdominal aorta exam may be limited by body habitus in our fluffy patients, bowel gas, and other confounders. If you're struggling to get images, here are a few tricks that might help. Firstly, more ultrasound jelly. There can never be too much jelly between the probe and the patient. Secondly, apply firm, direct pressure with the probe, sometimes to the point of patient discomfort, unfortunately. But hold this for about 30 seconds, and oftentimes bowel will float out of view. Finally, sometimes rolling the patient into the lateral decubitus position is enough to get those intestines out of the way. Thank you so much for watching. As always, please contact me with any questions, comments, or suggestions at Dallas_holiday or dallas.holiday@gmail.com.